He was a morbidly obese surgeon destined for an operating table and an early death. Now he's a rebel MD who is fabulously fit and fighting to make America healthy again. This is Stay Off My Operating Table with Dr. Philip Ovadia.
Hey, thanks for joining us, folks. It's the Stay Off My Operating Table podcast with Dr. Philip Ovadia. You're listening to this sometime in 2025, but we are recording it on the last working day of 2024. And Phil, with my research on our guest, I'm really excited to hear you two talk and maybe to get to interrupt now and then. So I'm not going to say anything else. Introduce our guest.
Yeah, no, I'm real excited for this conversation as well. As we continue to explore the areas of medicine that metabolic health touches, and we know it touches everything, but it's always exciting to kind of find practitioners from specialties that I haven't really seen practitioners from yet and discover new ones. And in particular, I discovered Christy because of a very interesting case report that she published, which was in my kind of area of interest, thoracic surgery. That's how we got connected, and we'll talk about that case report. But I came to find her story around metabolic health and how she's woven it into her professional life now. Very interesting, and wanted to share it and get it out there. With that, Christy, why don't you give a little bit of your background, kind of maybe talk about your entry into medicine, what got you interested, why you picked the specialty that you picked, and then we can kind of go from there as to how metabolic health entered your life as it has for so many of us.
Yeah, absolutely. So I got into medicine somewhat uniquely, I guess. I didn't have anybody in medicine in my family. I was just kind of a math and science geeky kid. I enjoyed understanding how things worked. When I went through medical school and into residencies, I didn't really know what I wanted to do. I thought I wanted to be a pediatrician or a sports medicine doctor or something along those lines. And then as I kind of delved into different things, I happened along kind of cancer-ish. I didn't enjoy medical oncology per se, but I thought the surgical oncology specialties and subsequently radiation oncology kind of really piqued my interest.
Okay, this is where I jump in and go, I didn't know about all these different things.
No, I didn't either.
Surgical,
yeah,
radiation
oncology.
You can explain those for us real quick.
Yeah, oncology is cancer, right? So
right.
Oncology, we in conventional medicine take out tumors with surgery, and those are different specialties sometimes. Sometimes we have gynecologic oncologists that do gynecologic surgeries or cancer surgeries. We have breast surgery, which wasn't actually a specialty. Back in my day, it was either surgical or gynecologic oncologists doing breast surgeries. And then we've kind of evolved from surgical oncology to specialties. So we have the colon cancer surgeries, we have the lung cancer surgeons, we have, liver surgeons, we have prostate surgeons, right? So all of the different specialties that do surgery. Medical oncology is oncology or cancer therapies that are medicines. So the chemotherapies and now the immunotherapies, also hormonal therapies. Those are very commonly, given by our medical oncologists. And then what I had no idea existed at the time was radiation oncology, and that is treating cancers with radiation. I learned of it as I did my rotations, in actually, as part of your OB-GYN rotation, I spent 2 weeks with the gynecologic oncologist, and I got into the surgical aspect of cancer. And I thought, God, this is really interesting. I think this is what I might want to do. But I also enjoyed radiology, and radiology was looking at images, but I didn't really like sitting in a dark room just looking at images and looking at a lot of just normal benign stuff. But when we saw the cancer stuff, I thought that's kind of interesting. And one of my professors said, why don't you look at radiation oncology? And I'm like, radiation oncology, what is that? The next rotation I did was working with a radiation oncologist, and it was really fun for me. I hate to say that oncology is fun, but it really combined the idea of surgery. Here's your problem. How are you going to fix it? How are you going to treat this particular focused lesion or combination of lesions. And my puzzling mind, I loved doing puzzles and, any kind of, three-dimensional pictures. But that's really what we started doing, is taking imaging and saying, how are we going to get treatment into this person, into this tumor, with the least amount of collateral damage or exposure. And as radiation oncology became more and more technical, it became almost more and more fun. Like, how do you use this three-dimensional information? Because when I was training, we were getting some three-dimensional imaging, CT scans, but we would have to transfer it onto a two-dimensional X-ray. And so there was a lot of math involved with trying to come up with these targets. But anyway, I really enjoyed kind of that piece of it, but I also loved educating patients. And I find, and this goes for maybe all specialties, but I had really good mentors in my life that taught me a lot about the evolution of what we were doing. We started with doing this for this particular case, but then we did this trial and we found that this was a little bit better. This was the pros and cons, and kind of I spent a lot of the time with my patients educating them on their disease and why we were recommending what we were recommending. And I was always one of the, what I would call an early adopter. So as we went from doing 6 weeks of radiation to breast cancer patients, we would do 4 weeks. And, when I left practice, I was doing 1 week of radiation for almost all of my breast cancer patients. And even today, that's still not happening because of those that are waiting for longer and longer term data. And sadly, the way that our reimbursement is that you kind of get paid for, and I'm not saying that doctors do this necessarily, but maybe, you get paid a lot more to treat 6 weeks than you do to treat 1 week, right? I mean, you get paid by the fraction almost. So you really, have to be altruistic, I think, in doing what's the best for the patient. I was always trying to stay on the cutting edge, and what could we do less of? When could we omit radiation? When could we do smaller volumes of radiation? When could we do fewer fractions of radiation? And, so that was always really fun. But probably for my own health, I struggled with my weight relatively all my life. Most people wouldn't think that I struggled with my weight, but I came from a heavier family, and I, kind of bounced up and down, never obese, never really big, but always just never quite happy when I was exercising, doing lots of activity. It seemed like it was okay. And then I got around, college, put some weight on, took it off, got to, had babies, put it on, came across Atkins, right? And I, of course, said the same old stuff that everybody else said. Oh my God, you're going to wreck your heart. You're going to kill your kidneys. That can't be good for you. And I decided to read his book because I kept just saying the same old stuff. And when I read the book and really looked at the data, I went, "God, this really actually sounds pretty impressive." So I decided to try it for myself, and I felt like $1 million. But I kind of did the usual, right? Oh, but then add more plants and add more this and add more that until you find I never felt good when I added more stuff back in. So I kept restarting. And it wasn't until maybe 2016 or 17, and I would say over those years. So I started this 22, 23 years ago. And I've been mostly low carb for all of that time, periods of ketogenic or very low carb. Started becoming more convinced that I needed to stay that way all the time, and started to hear more in the way of obesity and cancers. Okay, this was a big thing. So then I would try to educate on, hey, this worked for me, keeping my weight down. I feel so much better. Maybe you should try this. And so I would counsel on low carb quite a bit. But it wasn't until I really kind of came across the Thomas Seyfried and Nasha Winters and kind of this metabolic idea of cancer that, wow, this is insulin. It's not obesity, it's insulin, because we have skinny cancer patients. And so then I started really looking into that data, getting educated myself, and then starting to educate patients. But yeah, I mean, I definitely still conflicted with a lot of the conventional medical team saying what you eat doesn't matter, and don't tell these people who are losing weight that they should be following a ketogenic diet or, something like that. And I'm like, it's not a weight loss diet. It's to heal their metabolism. It's to improve their outcomes. And there is plenty, I shouldn't say plenty, but there is significant data out there, in the oncology space that really metabolism matters. and that insulin matters and that IGF-1 matters. And if we can eat in such a way that we can optimize those things, why wouldn't we? And I will have patients say, oh my God, but should I tell my oncologist that I'm doing this? And I'm like, why don't you just tell them you're eating real food, that you cut out processed food, you cut out sugars, because that's what you're doing. You're eating real food and you feel great. So why should they worry, But
yeah, very interesting to hear you talk about that. Cancer, I think, or the treatment paradigm around cancer, right, strikes me as having similar blind spots that, heart disease does. And I know, think back through all my education, medical school, and then, training to be a cardiac surgeon, focusing on heart disease, right? I don't really ever remember insulin resistance being mentioned as a factor in heart disease during all of that time. And it was only, similar to you as I went through my own journey that I came across this information that wasn't new. It just wasn't talked about. And we've, had Professor Seyfried on, and I've been fortunate to, talk to him other times as well. But again, in all that I remember learning about oncology during my training, I don't really remember insulin ever being mentioned. And I just want to ask you to go back through your recollection and, did you learn about insulin and insulin resistance playing a role in cancer at all?
Never, not once. And even when I started, banging the drum, it didn't matter. I gave talks to like medical oncology staff members, like nurses, PAs, and they're like, we don't even look. Number one, no one looks at insulin, but they will be giving chemotherapies, right? People are on steroids around chemotherapies. They'll have people with sugars in the 170s and they don't even look twice at it. They were like, wow, we've never even looked at it. We just figure, it's not low, and it's not too high, and, blah, blah, blah. So,
yeah, it's amazing. And again, not new, right? Otto Warburg figured this out in the 1920s, 1930s. One of those aha moments that occurred for me around cancer specifically is one of the main diagnostic tests around cancer is a PET scan. And the way the PET works is you take sugar, you give an IV of sugar to the patient. They label the sugar with a radioactive tracer so they can see where it goes in the body. And you track where the sugar goes in the body, and it goes to the cancer. And it's one of the basic tests, right? And just the way that test works should tell us all, maybe we should stop feeding sugar to the cancers. And yet no one makes that connection. Admittedly, I never really thought about it. And you probably looked at thousands of PET scans during your career and didn't think about it either, prior to sort of your eyes being opened.
No, and even the dietitians would say to me, because I would make that argument to them, and they would say, oh, but how would the body know, if it was coming from like fruit or good sugars or bad sugar? And I kind of laugh at them and I go, it doesn't. It's the same sugar. Like, you have to understand that sugar is sugar. Like, it doesn't really matter where it's coming from. But, I will say that we also misunderstand it, right? A lot of people in my world now, and we can go into where I am now, but I've cut out all the sugars and I've cut out processed foods, but they're still eating a high carbohydrate diet. So they don't really they understand, but they don't understand. And I wish there was more conversation, right, about insulin and what is your body doing with what you're eating or how you're eating, and how can we do better. Again, from a cancer perspective, and I see it very commonly, I do labs a lot because I like to not guess. People say, oh, I'm eating this way, I feel great. And I'm like, that's awesome that you're feeling great. Let's see where your markers are moving, because maybe we still need to make some tweaks. And what we find is that we just had a holiday, right? Oh, I didn't do very well over the holidays. I didn't do bad. I just had a little bit of this and a little bit of that. And, their numbers are telling us that was too much for you, because I will see tumor markers or circulating tumor cells or other tests that we'll use to kind of judge how well we're doing from a cancer perspective. And they look worse. So why are they looking worse? What was different? Oh, yeah, it was the holidays. Didn't do that well. So again, I'm not saying that was the only thing, but I see it so commonly that I really, I almost want to send out like an alert message around the holidays to everybody in my practice saying, hey, do not cheat. This is not the time to cheat. Like, we've got to stay on this and I actually give them a holiday recipe list even. Hey, let's stick to these things. It's tough. It's tough when it's constantly, the whole world is running against you when you're trying to eat and live well.
Yeah, definitely so. It is a challenging environment. I'd love to dig in a little bit more on what your practice looks like today. As I mentioned, we had Tom Seyfried on, and, just a wealth of information, but, kind of from the research aspects of it, you, as best as I can recall, are the first cancer practitioner that we have on to talk about, the impact of metabolic health. So maybe talk a little bit about what your practice looks like today and what you're seeing in dealing with patients that are making these changes around metabolic health.
Yeah. So I started to incorporate metabolic health, looking at insulin, looking at, triglyceride HDL ratio as a marker of insulin resistance, looking at a lot of different markers, even looking at vitamin D as another piece of my puzzle. A lot of these things within conventional radiation oncology, I was kind of ordering them. I would meet with patients weekly while they were on treatment. So I had a little bit of a capture. I had a lot of people take me up on making dietary changes. Not everybody, and some people wanted nothing to do with it at all. But about 3 years ago, I decided to actually leave my conventional practice and do 100% metabolic health, kind of health coaching almost. So I run labs, I give people diet advice. I sometimes recommend supplements for nutritional deficiencies that I'm seeing, or maybe something to help with inflammation. And then I get the people who actually want to hear the message, are ready to hear that message, or are looking to fine tune what they're doing. So now I run an online, basically telehealth type practice. I'm not acting as their primary physician. I'm not acting as their primary oncologist. I'm a team member. I'm a sounding board. So when they're talking about, and I don't dictate what treatments people choose to do. So I have some people who choose to do everything their conventional medical team recommends. They're oncologists, so chemotherapies and hormonal therapies and whatever. But I think the data that we have really suggests that combining metabolic therapies with conventional therapies are better than either by themselves. I think that I have some clients who choose to do nothing, that are kind of in an observation phase, others that are choosing to do alternative oncology type things like IV vitamin C or hyperbaric oxygen therapy or other types of treatments. And really what I like to do is to see them at least once. I've had some people I've worked with for a year before they decided to go on to do their conventional therapy, but now they were in such a better place. They felt better. They felt like they were ready to embark on something like that, where prior they felt so sick or tired or whatever. I've had some people, their tumors have disappeared doing a combination of non-conventional things. I've had others who've just stabilized their disease. Early stage prostate, we have those low risk prostates, and we're like, let's just watch you. Let's not do anything. Let's watch and wait, or active surveillance, it's called. And there's some data that's been published on, diet and lifestyle changes and maybe keeping things in check. And I've seen a lot of prostate cancer folks drop prostate markers. So PSA dropping, tumors on their MRIs getting smaller, lymph nodes disappearing, just by optimizing diet and maybe some of the nutritional supplements. But I've also seen it bounce back with, Christmas cheats. I've also again, people try lots of different things. So I'm not saying it's a one size fits all, but I have seen some really impressive stuff with, for instance, just some that really come to mind, a woman with a fungating breast tumor, which means that her breast tumor or chest wall tumor was growing out of the skin. It was red and ulcerative and ugly. And even before she started her conventional therapy, which was getting lined up, she changed her way of eating, and she went from a plant-based, vegetarian diet to a more animal-based ketogenic diet, and said, oh my gosh, my skin's already getting better and I haven't even started anything. So I do see some of those. And I'm not saying again that it's going to make everybody's tumors just disappear. I think that it's a nice augment. I think it puts a lot of stress on those cancer cells that really want that glucose. And then you give them some other oxidative strategies, and it seems to really cause some more, bang for the buck. I always say 1 + 1 = 4, when you're kind of combining some of these things.
Could I ask a question, a cancer-specific question? And this is going to betray the fact that I don't know what I'm talking about. Phil said we've interviewed Dr. Seyfried a couple of times. I love his model of how cancer cells actually work. It makes sense to me. The one thing that I've wondered is, I'll back up for our listeners who may not have heard Seyfried. Cancer cells are mutated cells that have lost the ability to convert glycogen to create energy out of it. Instead, they ferment the glycogen and make basically booze in your cells. But in order to get the glycogen into the cells, there's got to be insulin. And the organ that makes insulin is the pancreas. What happens if the pancreas is cancerous?
So very interestingly, probably the biggest, I think, link to pancreatic cancer is insulin resistance. Like those pancreatic cells have the same thing happening, and it's just a feedback, right? So when we talk about visceral fat or fat in your belly, and that insulin is a big driver of that visceral fat. The visceral fat goes into all the organs in your belly. It's not just fat, right? It's fat in your liver. It's fat in your pancreas. Those are signs that you have insulin resistance or higher visceral fat. And there's a really big, strong link between glucose levels, insulin levels, and pancreatic cancer. So even if you have pancreatic cancer, it doesn't mean you stop making insulin. You're probably making more and more insulin. Now, one of the problems with pancreatic cancer is one of the treatments is removing the pancreas or part of the pancreas. And now not only do we have digestive issues, so now we have food issues. Are we digesting, absorbing the nutrients we actually need? They're on high doses of digestive enzymes, and now many of them are needing insulin, type 1, right? They don't have enough insulin being made. Now they need to dose their insulin. But what are they dosing their insulin to? The amount of carbohydrates they're eating. So again, they're all interconnected. In my opinion, it doesn't matter the cancer. I think there's some degree of insulin or IGF-1. So for instance, prostate cancer, PET scans are not as useful there. They do use a type of PET scan, but not a glucose one. They now use what's called PSMA or some prostate specific molecule. But IGF-1, so insulin like growth factor 1, which is a sister hormone to insulin, is actually a much bigger driver in the prostate world, but it's not going to look exactly the same as like a glucose insulin, but it's very similar. So you put prostate guys on a low carbohydrate diet and you still see significant improvements. If you look at the links, PSA is a factor, but IGF-1 is a bigger factor. So it's really interesting. It still comes back to metabolism, regardless of the organ again, type 1 diabetics can still get cancer, right? Because a lot of type 1 diabetics also ultimately become type 2 diabetics because they just keep dosing their insulin to their carbohydrate. They haven't changed their carbohydrate amount.
Yeah, no, very true that, a lot of 1 diabetics live in a high insulin environment that's all exogenous, but because of the high carbohydrate diet, they end up on a high insulin environment. Just real fascinating to think about. And, pancreatic cancer was one of my early introductions, just as a sidebar, into the radiation oncology world as a medical student, rotating. My earliest surgical influences, Frank Rosado was a pancreatic surgeon, and we would do intraoperative radiation therapy, pancreatic bed. So these were, I mean, it's hard to describe to people that don't know, but these were just massive operations, sometimes 8 to 12-hour operations. And in the middle of the operation, we would wheel the patient with their abdomen open into the radiation, chamber, whatever you want to call it, the linear accelerator. And we would actually radiate after we had taken out the pancreas, radiate that area to try to kill off more cells. It was kind of heroic surgery. It worked a lot of the time. You earlier mentioned, kind of some of the things we used to do, but what fascinating work back then. Let's talk about, I think this kind of segues into the case report that you had published recently, I believe back in June or so, and we'll put a link to it in the show notes. But it was a condition that I have seen a lot as a thoracic surgeon. It's called chylothorax, and we'll go into what that is. But your case report was the first time that I had seen chylothorax associated with, and you wrote this report on treating it essentially with a ketogenic diet. And I just found that fascinating because I had never linked the two, although there are some links that should be somewhat, I guess, obvious now in retrospect, right? But I never put together prospectively. Let's start with what is a chylothorax. Let's explain that to people. And then maybe you can go into the details of that you published.
Yeah, so a chylothorax is essentially like lymphatic fluid, chylous fluid that ends up in the thoracic or chest cavity. And it most commonly comes from a trauma or a surgical injury to the thoracic duct during a lung surgery, although there are other reasons that you can get it. But in my world, the only time I would see it would be in my chest cancer patients who had undergone a surgery. Or sometimes even, I want to say I had one patient who was maybe a Hodgkin's lymphoma or some kind of a lymphoma that had to, but they were all still thoracic surgery cases or cancer. Sometimes a cancer induced it as well. But there is, so when we eat fat is packaged and then transported. So fat gets packaged into these chylomicrons, which are kind of big balls of fat, and transported through the thoracic duct, through the chest. And when we eat saturated fats, or fat in general, we get more, in theory, chylomicron or formation, bigger chylomicrons. So the standard of care for a chylothorax, a conservative management, so we're not going to just go in and surgically repair it. They often will say, let's put you on a low-fat diet so that you make less chylomicrons, so that there's less flow in that thoracic duct and less leakage of the fat, of the chylous fluid, into the chest cavity. Now, there are reports of using a quote unquote low-fat diet, but supplement with MCT oil, or MCT, medium chain triglycerides. The medium chain triglycerides are processed differently. So they go to the liver, the portal circulation. So they're not packaged the same way. So those are kind of the options: low-fat diet plus or minus MCT oil. Now, I had a client, one of my telehealth clients, who had a lung tumor. It was actually a very strange case of a meningioma. Meningioma is actually a brain tumor. And she had one on her lung. And they actually did CNS and spinal imaging to say this must be a metastasis from a primary meningioma of the brain. And they could not find anything in her brain or spine. And they took it out. But during that surgery, they created this chylothorax. And so she had been going to get what's called a thoracentesis, or a needle put into this thorax, into the chest cavity, and sucking out this fluid. And it was tested and it showed lots of triglycerides. It was definitely a chylothorax. It didn't have any cancer in it. So it wasn't a pleural effusion from cancer. It was a chylothorax. And she was getting it drained about once a month, about 1 liter of fluid out, despite she was following a very low-fat diet. She was feeling terrible. She did have evidence of insulin resistance. And if you look up meningioma, there is an associated with obesity. So again, anything associated with obesity in my book is associated with insulin resistance. She had other signs of insulin resistance because she had a lot of endometriosis, which is actually how they found the lung tumor, by imaging her belly for her endometriosis. And she was about to undergo another big surgery because she had big amounts of endometriosis. And then they found the incidental lung nodule. Long story short, now she can't go get her pelvic surgery or abdominal surgery yet because they're still working on the lung. So she had an embolization planned. I think it was like May something or June something. She was going to get the embolization. Until that time, they were just tapping her lung to take off the fluid whenever she was symptomatic, although she had a standing appointment. She contacted me because she's, okay, I know that when I'm done with this, I need to address my metabolic health. I need to get, I need to get healthy. Fine. I said, these are our options. One, you could add MCT oil right now because she was just doing a low-fat diet. Let's kind of tweak the foods you're choosing. Let's do that. I said, or you're already scheduled for drain, embolization. Do we just want to start working on your metabolic health now? You choose. I'm not going to tell you to do things differently, but if you want to. She decided, I'm going all in. I'm just going to do a ketogenic diet. I don't really care because my lung is going to ultimately have to go to surgery anyway to fix that duct. And she said the next time she went in for her scheduled thoracentesis, they did the ultrasound because that's how they were identifying where to put the needle. They would do an ultrasound of her lung and they would say, okay, there's where the fluid starts. We'll put the needle in below that level of that air and fluid level. And they thought the ultrasound probe was broken. So they went and they got another ultrasound probe and they did it again and they couldn't find the level. And they're like, we got to just do a chest x-ray. And her chest x-ray showed that it was much lower than where they had anticipated it being. And they're like, what are you doing differently? She goes, I don't know. I started a ketogenic diet. And they're like, we think that is doing something for you. So she continued on her ketogenic diet. And yes, eating high saturated fat. So she was eating red meat and cheese and heavy cream and fatty coffees. She was still incorporating MCT oil as well, but she was not like doing an MCT only type of diet. It had lots of saturated fats in there. And she went back again and it was even lower. And then they did a CT scan, and a CT scan, when you lay on your back, the fluid will pool along the back of your rib cage. And usually you will see this nice air fluid level. The air stays on top, the fluid falls to the back, and there's nothing there. It's gone. They can't see any evidence of fluid in her chest. And so they canceled her embolization, and she was able to go on to her pelvic surgery. But guess what? After the pelvic surgery, she was in the hospital. And what kind of food do they feed you in the hospital? It is certainly not good, clean, ketogenic food. So she did notice a recurrence. She said, oh, my symptoms are coming back, but not enough. And we had evidence that it had recurred to a small degree. So she went back on her ketogenic diet when she got back, and it went away. And since that time, she has been back in the hospital or gone off of her diet at times, and it has never come back. So with enough time, it fully healed. Then the question, though, being, why did a ketogenic diet fix it when in theory we were probably increasing her chylomicrons, her flow through? I don't know. But then I started to dig into, do diabetics, because you can always go to diabetic literature to kind of understand what insulin resistance might be doing. But they have elevated, so diabetics, and she was not diabetic. In fact, she probably looked really good from a conventional standpoint, right? But if you understand how to look at labs and understand true insulin resistance, looking at triglycerides, HDL, triglyceride glucose index, she definitely had some evidence of insulin resistance, which corrected, got better and better. But diabetics have higher chylomicron production. They have worse chylomicron clearance. So maybe there's some difference in the chylomicron processing of a diabetic versus a non-diabetic. So improving insulin resistance, improve trafficking of it. I don't know. Could it be that when we are in a ketogenic state or following a low carbohydrate ketogenic style diet, are we improving inflammation markers? So we're quieting inflammation. There is some data on ketogenic diets and wound healing. Could we be improving that wound healing along with. So I honestly don't know why it worked, but I'm glad she decided to do it and that we now have this case report, because now I think it warrants a clinical study. Let's compare a ketogenic diet versus a low-fat diet, or a low-fat diet with MCT oil.
Yeah, I love cases like this that really just demonstrate, kind of such the black swans, as they're often called, because here we have a condition. And again, as a thoracic surgeon, I've been dealing with this condition my entire career. It's not super common, but I see a few of them a year. They oftentimes are kind of, the patient is miserable because they're undergoing these repeated procedures to drain the fluid out of their lungs. Oftentimes, the only option is going in there surgically, and these can be difficult surgeries because, like you said, a lot of times the patients have already had surgery on their chest, and now you're going back in, and there's scar tissue, and you need to find where things are leaking from, which is not straightforward. I can tell you, having done many of these, and the first line treatment is usually have the patient eat basically as low fat a diet as possible.
A high carbohydrate diet.
Which is a high carbohydrate diet. But, the theory is that, the thoracic duct is carrying dietary fat essentially. And so if you reduce that, you reduce the flow through the duct. And, that works sometimes, not a whole lot of the time, but sometimes it works. But it's also very hard, and the patients, hate the diet. MCT, these medium chain triglycerides, as far as we understand, are a unique fat. They're the only ones that don't go through the thoracic duct. So that's one way of getting the patient some fat, because we know you can't survive long-term on a fat-free diet. Coconut oil, MCT oil can be used to supplement the diet, but a lot of the times, this has to be done through what we call parenteral nutrition, right? We just tell the patient not to eat anything, and we're giving them nutrition through an IV to be able to kind of provide this fat-free diet essentially, because people can't really eat that way. And yeah, it's a difficult condition. And here you are presenting a case where you put the patient on a high-fat diet, the exact opposite of what's typically recommended, and the condition got better. And I also love, that sort of demonstration of each time the patient would sort of go off the ketogenic high-fat diet, they would get some recurrence, although, the general trend was it was getting better. So it's really one of those cases that I think if clinicians are aware of it, really should make them, question what they thought was true around this condition and around, just the whole way that perhaps our fat processing works in the body. It really makes us think about some things.
And I wonder too, if you look at just the diet trials that have compared low carb to low fat, both of those diets do lower glucose and insulin. It's just that a ketogenic diet does it so much better. So was it really that they were eating low fat, and that's why clinically they maybe got, it's not a ton of benefit, but some benefit, but yet we got far more benefit in a low carbohydrate setting? Is it really about the fat and the chylomicrons, or is it about somehow insulin resistance or the setting of having some metabolic dysfunction, worsening that picture? I don't know.
Yeah, I mean, what we can say, we know, that chylomicrons go down when you fix insulin resistance. And we can measure this with VLDL, for instance, as one of the hallmarks of insulin resistant is the shift in the types of cholesterol particles, cholesterol carrying particles that patients have, and things like, the small dense LDL decrease when you use insulin resistance, VLDL, which is, essentially, and we won't get too deep in the woods on this, but essentially, VLDL is made up of chylomicrons, right? And those go down when you fix insulin resistance. There are lots of reasons to think this should work and make sense, But again, it's one of these areas of medicine where honestly, it probably just didn't occur to anyone to really, because of that dogma, right? That the way to treat a chylothorax is with a low-fat diet. And, so no one would ever think to say, what if we tried a high-fat diet that was also taking care of insulin resistance? And it just doesn't get connected. But I think your case report hopefully trigger more investigation around that.
Yeah, I would love it. We'll see. I don't know. I am hopefully I will also get to talk about this at the Las Vegas meeting in February. So hopefully we'll get it to more ears. Hopefully some of them being thoracic surgeons and their associated dietitians. But I think that's really where it has to go. But if you maybe had a couple of case reports, a nice case series, now all of a sudden you've got more data that this would be a really interesting randomized trial. Again, there's so few of them, it's hard to get a robust randomized trial, but.
Yeah, I know I'll certainly have it in my mind the next time I see a patient with a chylothorax. And I maybe I can add a second case report one day based on this. So that's great. Let's talk again, or talk a little bit more about, putting this into practice, what that's been like for you. What kind of response are you seeing from your oncologic community, we'll call it, around you, when you talk about these concepts and when you're dealing with these patients? Like you said, oftentimes you're not their primary oncologist. They have other oncologists involved in their care. What kind of, response are you seeing from the other oncologic practitioners around this?
Well, sadly, there's still so much resistance, and I have, some sad cases of, like a brain tumor patient who is following a ketogenic diet to recurrent, glioblastoma. And then her oncologist said, we think you're not feeling that well because you need more carbs. You should just eat more carbs. And so she eats more carbs and has grand mal seizure and has further progression of her tumor. It's really sad. And others, I love the ones who say, I'm not opposed to it. I don't advocate for it. I'm not going to help you with it, but I'm not opposed. Those are like, yay. Every once in a while, you have somebody who actually advocates for it. Pretty rare. I just tend to get the patients who have come across Dr. Seyfried or myself in an interview or one of my courses or something, or Dr. Nasha Winters, and I can tell sometimes when maybe something was talked about on a podcast, because then I get like a handful of similar cases or something. Oh, this must have been talked at a prostate thing, because all of a sudden I've got 4 or 5 prostate guys all asking the same questions, that's got to, or Dr. Seyfried gives a talk and they find me in that regard. So again, I don't think there's too many of us in the MD world out there. So I tend to, find the people who find ketogenic diets. And occasionally I will see patients who are not doing a ketogenic diet, or maybe haven't heard that. Maybe they got referred through a Facebook group or somebody else and they're on a plant-based diet. And I don't, as much as I say, are you opposed to giving this up? Or, are you doing this because you think it's the healthiest thing for you? In which case, let's run your labs. Let's see what I'm seeing, because I will often see micronutrient deficiencies or protein deficiencies or inflammation markers or something. And or insulin's way through the roof. And I'll just say, let's just do it a different way. Or this is what I'm seeing and this is what I think you should do. You choose, you want to do it. Let's look. And I have people on occasion want to do something different than what I want them to do. And so I'm like, let's get more information. Let's put a continuous glucose monitor on you. Let's look at your labs a little more frequently and see where they're going. Because every once in a while, things look dramatically worse and they can see it in their numbers and they go, oh, that was not the right move. Let's dial that one back. Let's try something different. So I always say that what I do now is I'm just providing information for you. Don't operate in a vacuum. Don't assume that you're doing everything right and just run with it. And then until the next, shoe falls, let's kind of stay on top of it, because we all feel great until we don't. So let's kind of maybe stay ahead of the game. And what are we seeing in these numbers? And, are things moving in what I would consider the right direction? And again, I'm trying to base my reference ranges on data. There's some data out of Canada on insulin and breast cancer. And so let's aim to get into these really nice optimal groups, or at least where their best outcomes were. Again, observational data is not interventional data, so it's different. We have to take it with a grain of salt, but I think we can see it over and over again in different aspects. So let's look at that. But I think that, insulin resistance comes not really from eating carbs or just too many carbs. Is it also a problem, right? We have a mitochondrial dysfunction, and that can come from lots of things, right? We talk about toxins to the cells, and that all these pharmaceuticals that are mitochondrial toxins, all of the environmental toxins, the glyphosates, the plastics, the omega-6 fats, we have so many. We're up against so much that sometimes it is helping somebody look at their products, their labels, and not just on food, but on products that they're using in their house, on themselves, etc. Let's do deeper dives and let's clean up everything, because we are eating what's on our skin and what's, in our water and what's in our air. And so really trying to help them look at their health from a different perspective. I always say that a ketogenic diet is a rock star, and I tend to favor more carnivore-ish ketogenic diets, the more, because I'm going so low in carbohydrate that it's almost a carnivore diet, and anybody wants to do a carnivore diet. But what I see a problem with is that some people will say, but I'm not eating any carbohydrates, but they're still actually not eating a high-fat diet. And so if you're bringing in way too much protein in relation to your fat, then we can run into some problems too. So sometimes getting these labs is saying, it really looks like you need to push on fat. Where are you? Or they're so not hungry that all of a sudden they're under eating every single day. And I'm like, you are losing nutrients. Like we need, proper vitamins and minerals to run that immune system, to run the whole system. So it's more than just about carbohydrates. But I will say that any form of a ketogenic diet does seem to improve our detoxification. It seems to help with sleep, which is where we do a lot of repair and detox. So again, I always say that a ketogenic diet is really nice and overarching, but I do find that some people do better with more carnivore approaches. And I find some people don't want to do that. And so then we use labs and we use monitors and we use other things to help us kind of figure out what might be their sweet spots.
I'm glad you brought up labs. I'm going to read from your website, and then I want you to expand on this. At KessRx, Dr. Kesserling takes out the guesswork. By using various forms of testing before and after making changes, we can assess how these diet and lifestyle changes are affecting you on an individual level. We can then make additional adjustments as needed and retest. And this is the bit I want you to expand on. Dr. Kesserling has created her own customized comprehensive lab panel, including many non-traditional markers to get patients started on the right path.
Yeah, so basically when I customize my panel, so when I build these panels, I can get more discounted rates. And so I kind of have come up with what I feel like are a really nice overview. And then depending on the patient's history, I might pull in some additional extra thyroid markers. I have a TSH, I have a cortisol, which is our stress hormone. I have insulin and IGF-1. I of course have a cholesterol panel, but sometimes we'll do a deeper dive, right? Do an NMR panel to look at all those particles or something because somebody is worried about their very high cholesterol and is that a problem? And so we'll look a little deeper dive. I look at things like what Dr. Naisha Winters of the book, The Metabolic Approach to Cancer, calls her trifecta. I think a client of hers named it that, but she looks at ESR or SED rate, erythrocyte sedimentation rate, CRP or C-reactive protein, and LDH, lactate dehydrogenase. So these are just 3 labs. 2 of them are kind of general inflammation markers. LDH we use kind of as a mitochondrial health marker because LDH, or lactate dehydrogenase, is the final enzyme that's needed to convert pyruvate into lactate. That is that glycolytic pathway. That's that Warburg pathway.
Okay, I love that you know all this stuff, but can you put that in English?
It is in English. It's just that we need enzymes to turn, one molecule into the next. So when pyruvate, glucose. We're burning glucose. Ultimately, it's going to turn into pyruvate, which normally would go into our mitochondria
Right.
to be burned in our mitochondria, turned into our
Right.
energy. When the
With you so
mitochondria are
far.
dysfunctional, the pyruvate more often will turn to lactate, right? So that's the fermenting part.
That's what Dr. Seyfried talks
Seyfried was referring to, right?
Okay.
So then if we're doing that, right, and these cancer cells are now having to take in 10 times as much glucose, right? Because that doesn't produce that much energy. So they need to do it more and more. So now they need more LDH or lactate dehydrogenase for that final step, because normally we only need this much. Now all of a sudden we need this much. So it can be a sign that, again, even though it's normal on your lab ranges, all of these are often normal on the regular lab ranges, but I'm looking at it with a different eye saying, ooh, that's higher than optimal, which is suggesting that your mitochondria might be struggling. And I can see that. And the worse the cancer gets, the higher that lactate dehydrogenase is. Now, sometimes it can come with cellular death. So as cells die and open up, it releases a lot of this LDH into the system or into the bloodstream as well.
So are there symptoms that just a non-clinician, a guy like me, could recognize in their own body as a warning sign that those cells are demanding more LVH?
Maybe. There are some people, like I think chronic fatigue syndrome and, even other chronic diseases can be associated with that. So it doesn't necessarily mean it's cancer, but I will say that's a late finding. So
It's a late stage of the process.
Right. So you could have a cancer, right? It's only this big. And so it needs more lactate dehydrogenase, but through your entire bloodstream, that's not really that big of a change. But if you had stage 4 disease or highly so again, sometimes, so I use that. I use other inflammation markers like fibrinogen and ferritin and uric acid I'll look at homocysteine, which is another marker of methylation. Methylation is one of our detoxification genes. We look at vitamin D. I look at all of our usual CBC and CMP, which are like the electrolytes and proteins and kidneys, and so liver, kidneys. I kind of look at everything.
Is there any blood left in a person after withdrawing all the blood you need to do all these tests?
Bloodletting is a good thing too, right? It helps. It's usually about, I want to say 5 or 6 vials to get my panel. So it's not terrible. Nowadays, when they only have to put in, one needle and then draw all the tubes, it's different than back in the day where you had to draw, stick you for every tube. So again, it's not very much in the whole scheme of things, because if you talk to most people that are going through insurance, for instance, you go to a hospital and you say, how much would you charge to do all these labs? They'd say $3,000, and I can get the panel for about $250, $230. So pretty inexpensive, but all of my services are outside of the insurance model. And that
all by itself keeps your overhead significantly lower, I know.
So yes, because it's just me, myself, and I now. Yeah, so very much. And then I feel like I have the opportunity to help more people because I'm not tied as much to, because I'm not practicing. I'm not being their doctor and just coaching. I'm just giving them suggestions, right? They can take them or leave them. I'm not prescribing anything. I'm just helping them analyze their own information. And then I'm also being their sounding board. Oh, my oncologist says this. And I'm like, have you asked them these questions? So I often give them questions to go back to their medical team to ask, or just help them sort out their own thought processes. What are you feeling? What are you thinking? How do you feel? Because our oncologists, right? It's do this, bye. So there's not as much time for that. Why would I want to do that? And I have some oncologists who don't want to answer questions, or maybe they don't know the answers to questions. Like, did you ask them, what is the absolute benefit? Because we're so used to talking relative benefit, so we can go back to the statins and what is your relative, but oftentimes I will hear from oncologists, there's a 50% reduction in risk. Yes, there is a 50% reduction, but did you ask them from what number to what number? Because I'm going to ask you right now, if it went from 2 in 1,000 to 1 in 1,000, that's a 50% reduction in risk. Is that 1 out of 1,000 chance that you're that person? worth it? Or what if it was truly, 50% risk of recurrence now down to 25% chance. So now that's a full 25% chance that you're going to benefit from that treatment. Yeah. And again, what benefit are we talking about? Overall survival, just recurrence-free survival, metastasis-free survival, just, again, there's so many nuances to how we discuss treatments with a patient. And so I'm just trying to make sure that they're fully understanding the pros and cons of whatever treatment it is that they choose to do or not do. Sometimes I have people that I'm almost begging them to go do conventional therapy because I know how great that response is going to look, and especially if we help protect them, because that is what we're seeing in the metabolic literature is that, fasting or fasting-like diets, right? Ketogenic diet is a fasting mimicking diet. So if we did some of that, could we get them through chemotherapy far easier, or hormonal therapy, or whatever, because that's what I learned in my conventional practice is I had so many women with breast cancer on hormonal therapies feeling terrible because of, making them feel menopausal and hot flashes and gaining weight and joint aches and whatever. And then I'd have them go on a ketogenic diet and those things would all go away. And you're like, so you choose, do you want to stop the medicine? Do you want to do the medicine with, metabolic health? Or do you maybe want to just do metabolic health? I mean, you choose. But that's my role, is really to try to get them to really think through what they want out of their course of treatment.
Yeah, folks, and it's so interesting, kind of the parallels between, I think, the cardiology world and the oncology world, and how these relative risks and, just get so overemphasized, and we sometimes lose that big picture. I'd love to, before we sort of wrap up, talk to the practitioners out there, maybe kind of think about, yourself, let's say, 5-10 years ago, as you're sort of first discovering this and thinking about how you can start to integrate it into your professional life. What kind of advice would you have for the practitioners who, they're learning about metabolic health, they're seeing the benefits perhaps to themselves, perhaps to a few patients of theirs, and they're really thinking about how they integrate it, how they implement it into their professional lives? What kind of advice you wish you had gotten when you were at that point that we can now give the practitioners that are at the point?
I think it's really the first advice is just remember that we've been fed a line on the whole meat and fat piece. I think that's number one, because in cancer, it's very prevalent, again, in the heart world too, right? No meat, no saturated fat. Those are red meat and saturated fat. They're going to kill you. Do your research. I mean, I have a number of courses online that I try to go through some of these myths and where did they come up with that data? And is it, and so it's really about, you have to self-educate because you're not going to get it anywhere else. So that's really what I did. I think I spent a year of watching every doctor who was already in this space. So maybe, 2016 or 17, really trying to educate myself. What books could I read? What cancer, experts are there? Who could I follow? But bottom line is we have to understand that sugar is a problem, and we can't keep saying that diet doesn't matter. I think that's number one. Diet does matter. And yes, anytime we get away from the standard American diet, we are going to do better because we're removing a lot of those processed foods. So any whole food diet is going to be better, but cancer and like heart disease, these are really typically insulin resistant folks. And so just getting rid of most of the carbohydrates doesn't always do enough. It's really about getting into that very low carbohydrate, high fat state where we are finally calming the system. And I wish I had some magic answer or way, but I would say start looking at insulin through a different lens. Don't look at insulin as per what the lab range says is normal. Look at what is optimal, which would be in the very low single digits, and how do we get patients there?
Awesome. For people that are looking to connect with you, maybe just talk about a little bit of what types of patients you see, how the practice works, and where they can connect with you.
The best way to get to me is through my website, which is kessrx.com. So KESRX.com. And you can actually book an appointment directly from there. You can get links to most of my presentations or course work that I've also created. And you can also direct email me as well from there. But usually I just say, make an appointment. I do, 15-minute discovery calls. I do charge a fee because otherwise I actually would never see patients when I was doing them. It's like my whole day filled up with discovery calls and I couldn't get my real patients in. But it does give an earlier touch base than what my schedule allows because I do book out a couple months usually. I do try to get more urgent patients in sooner, see actually everything. So most of my patients are cancer patients, but interestingly enough, I'm looking at my new patient schedule for this week, which is an abbreviated week because it's a holiday week. And only one of my new patients is actually a cancer patient. So I see friends and family. I see people who are diabetics or pre-diabetics. I see people who are just like, I just don't feel good. I want to feel better. I don't know what I'm doing wrong. I see a lot of people from the carnivore space that are maybe not getting success with just carnivore. And so we're trying to do deeper dives into labs and figure out maybe what else we need to be doing. So I see a variety, but again, I would say that the majority of my patients are cancer-related patients.
Yeah, I think all of us in the metabolic health world, the practitioners are experiencing just increasing awareness, increasing demand. And so we're all quite busy and looking for more to come join the army. For any of the practitioners that are listening to this and on the fence, get engaged in the community, good organizations like the Society of Metabolic Health Practitioners that we've mentioned many times on this podcast. And, I, at this point, consider it our duty in serving our patients the best we can. And anyone that's aware of this as a practitioner should be figuring out how to, make it a part of your practice, even if the system might not make that easy. So very good. Glad to have connected with you. We'll certainly put all the links in the show notes. We'll put a link to that case report as well, and look forward to talking more with you and interacting more with you as we try and spread the word here.
Absolutely.
Thanks so much for having me. It was a pleasure.
Our guest has been Dr. Christy Kesserling. Her contact information will be available in the show notes. Thanks for joining us. This has been Stay Off My Operating Table. We'll talk to you next time.
Chances are you wouldn't be listening to this podcast if you didn't need to change your life and get healthier. So take action right now. Book a call with Dr. Ovadia's team. One small step in the right direction is all it takes to get started. Contact us at ifixhearts.com/talk. That's ifixhearts.com/talk.